stuff. Nice to see you, Emma. Thank you so much for introducing me. I'm going to try and work the tech. If I get problems, I apologize, but hopefully for the next 15 minutes, I'm going to chat to you about this trial that I've appraised recently. I will start off by trying to share my screen. Hopefully this will work. He says, tentatively waiting to see if it will work for me. Is this sharing screen at all yet with you guys?
Not yet, Lee.
Have we got
that looks good
now? Excellent, excellent. Okay. Let's see if you get this coming up. Have you got?
Yeah, perfect. We can.
Presentation. Marvelous.
Yeah,
Thank
we
you.
can see it.
Hopefully this is going to run smoothly. I apologize if there's lots of audio and noise outside. There seem to be lots of helicopters flying overhead this afternoon, so apologies if it all gets a bit noisy. I'll try and make sure that I speak loudly enough. As Emma has said, I'm an ED consultant in Wessex. I work down at Poole Hospital in Dorset, and I was very lucky to be a Wessex trainee, a fantastic region to train in. And then when I finished, I became program director and then head of school for emergency medicine. And essentially, I'm going to talk to you about this paper that came out literally a month ago today. It's to do with decision aids and the use of CTCA, computed tomography, coronary angiography, in patients with suspected ACS, that came out by Dr. Weng et al. Literally a month ago today. So hopefully I'm going to make it vaguely interactive as much as you can when talking to a big group of people. But yeah, try to stay awake with me for at least the next 14 minutes or so. Thank you. A couple of introductions and disclaimers. Well, I've already introduced myself, and I indeed will be watching the football tonight. Let's hope that England can manage to do well. Other disclaimers. I love emergency medicine. I think we are very lucky that we get to make people better for a hobby, and they pay us to do it. So I think we're incredibly fortunate to do our specialty. And I also love evidence-based medicine. I think that I was introduced to it as an SHO, having never heard of evidence-based medicine before. And certainly when I became a registrar, my consultants around me showed me how important evidence-based medicine is, because it really does make a huge difference. I work occasionally as an RChem examiner up at the Royal College of Emergency Medicine, and I tend to volunteer for and get pinged for critical appraisal stations. I'm not sure if that's an accident or not, but I actually quite like critical appraisal, and I think it's an important part of the stuff that we learn. And the reason that I chose this paper particularly is because of this scenario that's in front of you. This is probably something that rings true to most of you there. For example, a few weeks ago, we had a 45-year-old female that came to the ED with a reasonably typical story of central chest discomfort that she'd had for about an hour in duration. She had no particular great exciting history other than she'd been told in the past that she had high blood pressure, but she wasn't on any medications for it, and she had no family history of ischemic heart disease, didn't smoke, wasn't diabetic, etc., etc. She'd been sent up by a GP because she'd had this chest discomfort, and she came in, she'd had an ECG done at triage, which the triage nurse looked at and said, well, looks pretty normal. Then gave it to an SHO who thought, yep, looks pretty normal. I had a look at the ECG and I thought it looked pretty normal. And I'm sure that even if Dr. Ibrahim was there, he would have said that the ECG was pretty normal. And frankly, if Dr. Ibrahim says that an ECG is normal, then you're on pretty good grounds, really. This lady then had a troponin done at the 3-hour mark, and that was normal. And then it's a difficult question about what you do next. You probably don't need to rush this patient off to the cath lab, but you can't deny the fact that it's a bit worrying that you haven't got a reason for this lady to have had the chest pain. So down in Poole, we use the heart score, which may be something that you're all familiar with. And I certainly hadn't heard at that point of the troponin-only Manchester ACS score, which is what this paper talks about. And it'll be interesting at the end to find out which scoring system you guys use in your hospitals. So this paper basically, as I said, came out a month ago today. I don't know if many people have read this paper. I think that there is a pretty good chance that this is going to feature in mock exams coming up. And I think that there's a fair chance, a bit like Gareth's paper before, that this could come up in fellowship examinations because it was a pretty well-designed paper. It's quite a good paper to dissect. And if any of you have got exams coming up, it'd be worthwhile having a look at this paper and seeing how this diagnostic paper contrasts with the therapy paper that Gareth was talking about before for Reboa. And so I always start off with any paper about, well, what would a good paper look like? And very boringly, I always go back to my med school and FR Chem days and think, right, well, one of the first things to work out is it interesting? Is it relevant? Is it exciting? Is it affordable? And more than anything, is it a valid paper? Because frankly, if it's not valid, then I'm probably not going to go much further. And I've just summarized on this page GEARS and RAF-BES, which is the system that I use to try and work out whether or not a paper is valid. You may have your own system. Feel free to use it. Equally, if you want to steal this way of doing it, feel free. It's already been touched on with Gareth's paper before about therapy papers, about how it's really important that it's randomized, that the patients are assessed in the groups that they were assigned to, and that they're followed up, and also that ideally patients and staff would be blinded to what's going on. They'd have equal treatments other than the intervention, and that they'd have similar demographics from the outset. But this being a diagnostic paper, really, it's the GEARS that I use. So did they use the gold standard? Was it exciting and interesting? Was it applicable to my practice? Does it represent similar patients to what I would see in my practice? Was the study repeated in a second study? And did they apply the standard regardless of what the test result was? And I don't know if anybody's read this paper. I certainly thought it was exciting, applicable, probably is representative of my patients. This was set in Edinburgh in the National Health Service, where ischemic heart disease is at least as prevalent, if not more prevalent, than we see down in Dorset. From my own perspective, as I said, we use a heart score and we do see similar cases. I've certainly never used the Tmax score before, but I'm sure that's something that we could think about. And we do have a CT coronary angiogram on site, although it's difficult to get hold of out of hours. And it usually then has to be reported by a radiologist and a cardiologist. And when we look at this paper, essentially the way that they did this paper is they looked at another study and they excluded all of those patients that hadn't had a CTCA, and they excluded all of those patients for whom they couldn't calculate a heart or a Tmax score, which left about 40% of the people that entered the study being looked at. But one of the weaknesses of the study is that they didn't repeat this in a second study at all. And the long and short of it is that the paper shows that both Tmax and heart perform well. Tmax is the troponin-only Manchester acute coronary syndrome scoring system. And I've outlined what you do for Tmax and heart just below there for those of you that haven't seen these before. I've worked in a previous trust where we used to use the GRACE score, but the GRACE score performed poorly in this study and showed that both Tmax and heart were a better way of doing things. I'll just quickly summarize the heart score for those of you who haven't seen it before. Essentially, you take a history from your patient and then you try and subdivide as to whether or not that it's a low likelihood of being cardiac chest pain, or a medium likelihood, or a high likelihood. Is it a very convincing story? It's quite subjective as to whether or not you're convinced by the pain, but that's one of the flaws of the heart score, really, is it is quite an individual view of how convincing it is. It then also asks you to comment on whether or not you think that the ECG is normal, has some non-specific T-wave changes, or has obvious ST depression. And then the age range, under 45, 45 to 65 or over 65, and then the number of risk factors that you've got. And if you've got known ischemic heart disease, then you get the maximum score straight away. And then finally, it's about how high the troponin goes. Contrasting to that, the Tmax score that, as I said, I hadn't used before, interestingly, it looks at several things, including troponin levels and chest pain and whether the pain radiated to the right arm or not, but also whether or not the ECG was ischemic. And it puts some weight on whether or not your patient was sweaty or not, which isn't something that I've ever really thought of or applied to my patients, and thought that, well, he's not sweating, so therefore it can't be serious. But it's an interesting way of looking at things. So what did I learn from this paper? It certainly seems that across the UK, at least, different departments are doing different things. Some places are using the GRACE score, some places are using the heart score, some places are using the Tmax score. And as they showed in this study, Tmax certainly outperforms heart, which outperforms the GRACE score when it comes to looking for acute coronary syndromes. And when you combine the Tmax score with CT coronary angiogram, it's very likely to rule out acute coronary syndrome. And it also has a use at spotting how many patients are going to need revascularization at the 30-day mark. They essentially concluded that Tmax combined with CTCA improves your diagnosis of ACS and improves your chances of being able to spot those patients that need coronary revascularization. And as I said, it also showed that Tmax outperforms the heart score. There are a few weaknesses of this paper. I'm not aware of many places in the UK that use Tmax. Certainly, I've never worked anywhere that uses Tmax, but it's not insurmountable, and I'm sure that it's something that we could use to replace the heart score if needed to. I'm not convinced that many hospitals can afford or can obtain CTCA in the emergency department in a timely manner. It's something in Poole Hospital that we tend to ask the medical team to do. So we would have somebody like my 45-year-old patient, and we would calculate her heart score or a Tmax score, and then we would refer on to the medical team, and a CTCA would probably be done either the next day or at an outpatient view in the next few days. Whereas in this study, they were retrospectively looking at whether or not patients had Tmax and CTCA done in the emergency department, which sounds great, but I think it's not very likely to happen in my department. They also only followed up patients for 30 days after the study had been done. And whilst that's reasonably impressive, actually, we don't know if on day 31 people are dropping dead or whether or not they're having more complications. So I think that a study that was following up patients for longer than that would be better from my perspective. I probably want patients to be followed up for probably 6 months minimum if we were going to be seeing what actually happens to these people long term. As I mentioned, it was looking at a different study. Essentially, it was a retrospective analysis of a different study that was done, which was a multi-center RCT. And the only other thing that I pulled out of this, as far as weaknesses of the paper go, are that several of the authors that wrote this paper had competing interests. Pretty much just over half of them were involved and had research grants with various organizations that you could argue were confounding factors in all of this. So really, will this change my practice as an EM clinician? I'm already familiar with a heart score. I suppose we could discuss it in our department and see whether or not moving to Tmax is something we wanted to do. In this study, it showed a slightly better performance with Tmax compared to heart, but for all of the hassle that it would take in order to change how we do chest pain scoring and convince the medical team that that's the same and get the buy-in from cardiology, I'm not sure that moving to Tmax from heart is necessarily worth doing. It may be that I think about ordering more CT coronary angiograms on patients with high heart scores, but I'm probably not going to keep them in the ED to wait for their test result, because that's going to need a cardiologist and a radiologist to be looking at those to give me a meaningful result. And for all that I'm an enthusiast, I'm not sure I can be looking at CT coronary angiograms and making a meaningful judgment call without getting it wrong. And then there's also the cost. at the end of the day, the NHS is not driven by private healthcare and it's not driven by money. I have to do the most for the most with the funds available to me. And therefore, I probably can't afford to do CTCAs on what would probably be 20 to 30 patients a day, lest the finance manager come and chase me around the department, wanting to know where I'm spending all of their money. The final thing I was going to touch on for the last couple of minutes, I hope it's useful for you guys, but is the questions that I ask of this paper are pretty similar to the questions that we ask at FRChem with regards to questions generally on any critically appraised paper. And I've highlighted them here. So hopefully this will be useful for any of you that have got exams coming up. We tend to start the batting with, what did you think of the paper? Just to check that the individuals actually read the paper. You'd be surprised how often that hasn't happened. And then we tend to ask things like, was it a valid study? And if not, why not? And this is where it comes down to you having your own definition of what makes a valid diagnostic therapy study, et cetera, et cetera. We tend to ask how you might have improved the study design. And again, that's knowing about validity and what makes a study a well-designed study. And then a variety of things such as what kinds of bias do you know, what kinds of error do you know, what kinds of randomization do you know, what's the difference between p-values, odds ratios, numbers needed to treat, confidence intervals, etc. Definitions about sensitivity, specificity, absolute risk reduction, etc. As well as things about normal distribution, skew, and all those sorts of things. If you're not too hot on your definitions and these sorts of things on this page, I would suggest to you a post-it note and writing all your definitions out and having them dotted around the house in the weeks before your exam, because it certainly is quite a good way of improving your memory of all things statistics, really. And so the bottom line of all of this would really be whether or not you'd implement this in your emergency department, and if so, how. And that's something that we often ask in the FRChem exam. And that's a combination of thinking that a paper is valid, but also whether or not it's applicable and affordable to the patients in your department. So I think that is pretty much me bang on to time. And regardless of what it says on the picture there, feel free to ask any questions.